course we start with cardiovascular system, then we go on with other systems. So that's why today we have lectures on cardiac pathology and vascular pathology. So I hope you remember what is pathology, because you did the general pathology and the branches of pathology and the fields of study of pathology, as you have seen in the introductory course in general pathology. So I think this can help us to maybe to remember what you have learned. So someone can just type in the chat. So comparing 1, so on the left side 1 to 5 in the Roman figures, and then on the right side we have numbering using letters. So you can write, for example, 1A or 2A and so on. So I think we can just have 1 minute for that. It will not be marked as such, as just for you to remember what you have learned. I think 60 seconds will be enough. Okay, I see that if you have written the chat, so you can continue, but it was just an exercise to help you to come back into this mode, into pathology. So systemic pathology or general pathology start with 2. General pathology, as you know, is the study of general principles of diseases, because as you learned, pathology is a science of disease, and the disease we have seen four I think what I can call 4 stages of disease process. There is a etiology, pathomechanism, biochemical changes, structural changes, and then clinical implication and prognosis. So systemic pathology will be then a study of specific organ or system diseases. So meaning that 1 is linked to B and 2 is linked to A. So pathology, you have seen also that pathology is interesting because it is a science that links basic sciences to clinical sciences, clinical branches of medicine. So in basic sciences, we have courses like anatomy, histology, physiology, molecular biology, and so on. In order to link these to clinical sciences, pathology must be in, because with it, you start now learning about diseases and still link the diseases to the basic sciences. So anatomical pathology uses the following methods, like cytology, meaning the study of cells to determine any changes causing diseases. A biopsy or histology or histopathology, which uses tissues to see changes which happened at the microscopic level in order to determine a disease. And this is what we do daily to diagnose diseases such as cancers and others. And then clinical pathology, like here, is it will be it is not a component of anatomical pathology. This is the answer, because clinical pathology, you have seen that it includes branches of medicine such as hematology, biochemistry, immunology, and microbiology. So these ones are not anatomical pathology part, but they are clinical pathology component of pathology. So it was just a reminder about the principles of general pathology and how we can link it to systemic pathology. So in systemic pathology, we will apply the principles we have learned about diseases in general. So we link them to every organ. So each organ, as you have seen in general pathology, you have seen cell injuries, you have seen infection, inflammation. So meaning that you are going to learn diseases of the heart. Someone having a mic on, you can mute yourself. So if you are going to learn about the heart, we will have to see inflammations. Among them, we can have infections. We'll have to see neoplasms, benign or malignant. We have ischemic diseases, meaning this is a part of cell injury, as we have seen in general pathology, and so on. So at each system, we will apply these principles. That's why in pathology, usually we classify the diseases of any organ among the developmental disorders, for example, malformations. Then we go to the inflammations. We go to neoplastic diseases, which can be benign tumors or cancers. So that is in general what you will have to learn about each specific organ of our body. So whenever you have a question, you will just can talk and ask your question. So these are the main references you can read. The Robbins Basic Pathology, it is actually the main book used in teaching pathology, the general pathology mainly. And then we have other books which are used in systemic pathology. Some are listed here, and there is a website called the Pathology Outlines, which is very helpful for having summarized each diseases into the clinical aspects, investigations to be done, how histology will look like, what are the molecular aspects of that disease, and so on. And it has many pictures, gross images, and then microscopic images. Pathology outlines. So for any organ, in order to understand the diseases, it is always good to start with basic science, anatomy, histology, and physiology whenever we have time. But when I don't present them, you can read them, or I think they are just simple things most of the time. So for the heart, you know that it has chambers, which are the left ventricle, the right ventricle, and then you have the right atrium and the left atrium. Then we have valves. For example, this valve, it is between the left atrium and the ventricle, and here we have another valve which is between the right atrium and the right ventricle. You know that we have other valve, for example, aortic valve. We know its function is it to avoid the blood to return back when the heart has pumped the blood through the aorta, so that there is no regurgitation. This is the role of this valve. Also, the other valves also, they are there just to avoid the blood to go back to the previous chamber. If for example, the blood has left the left atrium going to the left ventricle, when the heart is pumping, the blood can go back to the left atrium. So this valve must close the area here, so that the blood doesn't return to the left atrium. Instead, the blood to go to the aorta. And then when the blood has already entered the aorta, this valve also will close to avoid the blood to come back from the aorta to this ventricle. So this you have seen in physiology or other causes. So in order to pump, you know that the heart must have a muscle, and this muscle is thicker on the left side, because the left side has to pump blood toward all the organs of the body. The left side pumps, the right side pumps the blood towards the lungs. So therefore, it doesn't need to use too much energy. So that's why you will see that the thickness of the muscle here is smaller than on the left side. Of course, that is in normal conditions. Otherwise, if a patient is having a hypertension, pulmonary hypertension, meaning that there is a high pressure towards the lungs, in that case, this ventricle will be more hypertrophied compared to the left one. Of course, people with hypertension, systemic or arterial hypertension, they will have a thickened left heart muscle. So in order for the blood not to clot inside the heart, there must be a membrane here, a membrane which doesn't activate the coagulation of the blood inside there. So we have here we have endocardium. And the endocardium, it is like a continuation of endothelium that you have seen in vessels in the anatomy, and we can see that in the next presentation. So that membrane is lined by a simple squamous epithelium that is called endocardium here, and beneath it there is just a stroma having small blood vessels which bring nutrients to this endocardium. So you will understand that if there is a lesion into the endocardium, then there are some consequences. If there is, for example, some cells which have died, as you have seen in inflammation, whenever there is a lesion on the endothelial cells, usually there will be a reaction by the body. The blood clot will appear there. So normally the body will fight, so that, of course, the blood clot will be necessary there to avoid, to prevent the hemorrhage, so that the blood doesn't escape the vascular lumen. But when that blood clot stays there for a long time, it can cause serious problems such as thrombosis, as you have seen. So it is the same for the heart, as we shall see. If there is a blood clot inside here because there has been a lesion on the endocardium, there will be a blood clot. And if that blood clot, for example, is on the right side here, there is a risk that the heart will pump that blood clot to go to the lungs. And when it goes to the lungs, the person will have a pulmonary embolism, which is a very deadly disease. And if the embolism, if the thrombosis happened in the left side of the heart, then there is a risk that the heart will pump that blood clot through the aorta. In that case, it can go either to the cerebral arteries, it can go to the limbs, it can go to the heart itself. Because, you know, when the blood enters into the aorta, there will be some branches from the aorta which will bring back some blood to the heart to nourish it. That is why here you can see some vessels here, small vessels, the coronary arteries. So if the clot goes to the coronary artery, it means the blood which could come to nourish the heart itself will not reach some parts of the heart, and therefore there will be ischemia and necrosis, and this also we shall see. But if I come back on the endocarditis, on the inflammation of the endocardium, the most known areas to be affected that are valves, because valves are mainly just endocardial cells. So it is the valves are the main parts of the heart affected by endocarditis. So what I can say for the myocardium, the main issue is ischemia, which can be caused by embolism inside the coronary arteries. Then you know that also there are chambers here, the pericardium. So pericardium, they are membranes just around the heart, and as you know, for any visceral organ, we will have a visceral organ, a visceral membrane, and a parietal membrane. And between the two membranes, we have a space here. That space is usually filled with erythroid. That erythroid is to allow the heart to have a smooth movement. When there is that fluid, the two membranes, they will be having a smooth surface, so that when the heart wants to pump, it will bounce very easily. So that these two membranes also can be affected by different pathologies, such as inflammation. In that case, we say pericarditis. We see sometimes the patient having a pus inside, or there can be hemorrhage inside, or any other kind of inflammation. So this also we shall see. So when then we discuss disease, we understand where we are looking at. So it can be the endocardium, it can be myocardium or pericardium. So this is just like the anatomy, the physiology. So when the heart is pumping, what is happening? So, for example, in this case, here you see that there is atrial systole, and here when there is atrial systole, it means the blood is leaving the atria and it is going to the ventricles. So in that case, you can say that there is a contraction of the atrium, but that is a passive thing, because when the ventricles are open, they create a negative pressure, so the blood will go there from the atrium very easily. But for the blood to leave the ventricles, there must be a powerful contraction, which is here ventricular systole. So in that case, the valve between the atrium and the ventricle will close, and the valve between the ventricle and the great vessel, either aorta or the pulmonary artery, will open, so that the blood goes there. So it was what I was saying before. So in anatomy, again, you remember that we have different vessels and large vessels, and most of them we can see them through the pericardium, the visceral one. These are coronary arteries, and they have their branches. So you will hear me, for example, saying that when there is ischemia caused by thrombosis through the coronaries, usually it is maybe the posterior intraventricular branch which is affected, and so on. So you will remember where these vessels are. This is important. So the blood supply to the heart is done by coronary artery and vein system. So I have coronary arteries and coronary veins. The right and the left coronary arteries branch of the aorta. So the blood coming to nourish the heart doesn't come from the heart itself. The heart must pump it through the aorta, and then from the aorta, the blood a small part of the blood comes back to the heart to nourish it. So the branch, there's the aorta, they branch into smaller vessels. So the cardiac veins deliver blood to coronary sinus and back to the right atrium. So the blood, it means the vein of the heart, they bring back their blood to the right atrium. So you understand, it comes to the right atrium, then it will go down to the right ventricle, and then the blood will be pumped together with the blood from the other organs going to the lungs to have more oxygen. So as I said, the valves control the flow of blood from one chamber to another, and I explained this, and they prevent backflow or regurgitation, as I said. So that was just a reminder about the normal things, the normal anatomy, histology, and physiology of the heart. So we will start here with coronary artery disease, because these are the main. Here I must mention that each organ has many diseases, and usually you cannot know the number of typical diseases that can affect an organ. So what we have to do in systemic pathology, like in other clinical sciences, we just choose the most common or the most dangerous diseases that affect each organ. Otherwise, we cannot discuss every disease. That is not possible. So here then we'll discuss coronary artery disease. So when you hear about coronary artery disease, you understand that it is a vascular problem of the heart. So meaning maybe there is ischemia. Here we talk mainly about ischemia of the heart and its consequence. So the coronary artery disease results when coronary arteries cannot deliver blood adequately. So the usual cause are plaques in the arterial walls. So plaques, you have learned about the atherosclerosis. So you have seen that in atherosclerosis there is a deposit of fat, and then that fat will cause reaction. With reaction, we have macrophages coming in, and then when some cells are dying inside there will be formation of cholesterol salts, because there will be calcium reacting with fat, so causing salts to happen. So these ones, as they enlarge, they form plaques, and sometimes it is a larger plaque that will occlude either completely or almost completely the blood flow. So in that case, then we have a disease called Angina Pectoris. It is not really a disease, but it is a manifestation that there is ischemia. So when there is ischemia, I've seen that it is transient, meaning that it can be reversed. So when there is so when there is when there is a cut of the blood supply to the heart will experience ischemia. So ischemia, it means the cells are reacting, they are injured, but they are not dead. But when the angina pectoris lasts for long, or the ischemia lasts for a long time, then the cells will die. In that case, we talk about myocardial infarction. This is what the common people are around who are not health professionals, they call heart attack. So heart attack, it means a part of the myocardium has already undergone infarction or necrosis. So the necrosis of the myocardium, in other terms, is called myocardial infarction. It is like the necrosis of a brain, a part of the brain. It will be called the strokes. So stroke and the myocardial infarction, they are like the same, but the difference is the organ which is affected. So when the supply is that is completely blocked, the muscle dies, so which is myocardial infarction. So here, angina pectoris or ischemia of the heart muscle is reversible if you intervene as quick as possible. But when the muscle has already died, undergone a necrosis, then it is irreversible. It is a myocardial infarction, meaning that these muscle cells will not be replaced by another muscle, and the healing here process will be fibrosis if it happens. Otherwise, usually the patient dies automatically. So this is a picture showing you a coronary artery. So this was its thickness, the outline of the artery. It had a lumen. So, and now the remaining lumen is only this one. I think the lumen should have like of this size where I am navigating. But now you see that a lumen is very small, and you understand the consequence. The blood going through here will be of a very small amount as compared to what was supposed to be. And what is the cause? You see that here, or the wall of the coronary artery here, we can consider it normal. But the wall here is very thick. Why is it very thick? Because there has been an atheroma. And within this atheroma, you have something here, you see that it is somehow blue. So in histology, when we stain with hematosis and eosin, and we see a material which is acellular, meaning there are no cells inside there and it is bluish, we consider it as a calcium deposit. So it means this is a calcium deposit because it is right, so we call it calcification. So this calcification is within this large atheroma here, which has caused the sub-occlusion of the coronary artery. So otherwise, around the coronary artery here, you have adipose tissue here. So the first alloy is showing the remaining lumen, and the other alloy is showing this calcification. So here the picture, this is histology, is showing the thrombosis inside the coronary artery. So the lumen was here, but it is no longer there. There is a blood clot which is reddish. But for me, because I'm a pathologist, I can see these are cholesterol clefts. These which seem to be like needles are whitish. So they are whitish because they cannot take a stain. The stain is taken by here by the blood cells, and the fibrin which is deposited there because of thrombosis, and there is a few fibrin. And the whitish area here, looking like small needles, these are cholesterol clefts. So meaning that it has been a calcification caused by cholesterol clefts, but there is no free calcium. That's why there is no blue or material. So this vessel is completely occluded. So as a medical doctors, you know that as soon as you graduate, whenever you go, if they bring you, for example, a dead body, a medical doctor is entitled to examine the dead body and determine the cause. So usually when you do autopsy of the dead body, if the patient had died because of the heart attack, you will cut the coronary arteries and you will find some of them being occluded like this. And if you are not sure of what has occluded the lumen of the coronary artery, then you can send the specimen to histology. Then they will tell you this was a thrombosis or that was another thing. But at least you will have determined the cause of death. Okay, so the complications of occlusion of the coronary artery or thrombosis in the coronary artery, as you can understand, if there is this complete occlusion, the part which was nourished or irrigated by this vessel will not receive blood. If it doesn't receive blood, that part will undergo ischemia and then infarction. So that's why here they say complications will be myocardial infarction if it is if the thrombosis happens in the coronary arteries. If the thrombosis happens into the cerebral arteries, the patient will experience a stroke or a cerebral infarction. If the artery which was blocked, it goes, for example, to the limb, lower limb, upper limb, or intestines, that part will undergo infection, which usually is black, and we call it gangrene. You will see some patients in any hospital or even health centers having gangrene, especially, for example, those having diabetes mellitus, because they're the ones having this problem. Their vessels are easily occluded. We will see patients having amputation. They remove the part which is necrotic. So for you to know the limb has undergone a gangrene, you will see it black. And when you touch, you find that there is no sensation, there is no blood going there. So you will diagnose it as a gangrene. But you will have, of course, to determine the cause. So the kidney failure can happen if there has been a kidney infection. Of course, in that case, there will be a kidney failure, especially a kidney failure will happen if both kidneys are affected. Another complication is the aneurysm. Aneurysm, you have seen in general pathology, there will be outpushing another. So the body will try to make another vessel, if you can say so. So it will create, for example, a way through the wall of occluded blood vessel to create another way for the blood. But usually that will not be successful. So the blood will continue just to turn around in that pocket. So another consequence, it can be a rupture of that vessel or that aneurysm, and also thromboembolism, meaning that if there has been a thrombosis, that is occlusion, you can have a small part from it now continuing to go into further vessels and causing occlusion of a vessel far from where the thrombosis happens. And this is usually where, if a thrombosis happens inside the ventricle of the heart, or if the thrombosis happens in the veins. And in that case, we have a thromboembolism, meaning that it has been a thrombosis, then the part of that blood clot will go through the vascular system to occlude somewhere far from the site of thrombosis. So this is the summary of what I was saying before. Here we have different organs here. The different organs are on the upper part, and in the lower part you have a degree of occlusion of a vessel. And here you see that, I think you have seen this in atherosclerosis. Atherosclerosis, it is a disease affecting older people, but usually it starts when someone is very young. For example, here they are showing that at 10, between 0 and 10 years, usually there is no problem, and no structural problem or no anatomical problem. So if there is a deposit of the fat, usually you can't see it. You see just some streak, but if you palpate, you will not feel some swelling. But as the time goes on, so you can see that at around 10 years, you can have, here there is a small yellow thing here. So this is a fat which has already accumulated beneath the endothelium, because we are talking about a vessel. And grossly, where if we do autopsy or surgery, usually you will find lines, we call them streak, fatty streak. You will find lines here which are yellow. So don't think this is just a simple thing. If you see it, you must say that this person was having atherosclerosis, but in other stages, because it is just very shallow. But if it is a young person and you see it during surgery, after surgery, you must just explain to that patient and the family to take more measures to control the fat intake and so on. So as the times go on, we can have a fibrous plaque. Here it is large. You see that now the lumen is decreased maybe at 20%. And as time goes on, you see that at around 40 years of age, then problems come. So why? Either, as we shall see, this thrombosis here, or no, not the thrombosis, this plaque, atherosclerotic plaque here, can undergo hemorrhage. If it undergoes hemorrhage, then there will be a blood clot which will come and be added to the plaque, atherosclerotic plaque itself. So meaning that this patient will have both an atherosclerosis complicated with hemorrhage. So you see that now the lumen is more occluded. There is two small parts which are left for the blood to pass through. So here in thrombosis, you have seen that in atherosclerosis, you have seen that their complications include thrombosis in this case here, because there is a blood clot forming here. There can be plaque rupture. Plaque rupture, of course, here it happened and it caused the thrombosis, but sometimes there is plaque rupture but without thrombosis. And the hemorrhage, of course, and there is a wall weakening. So when the wall is weak here, then the complications can be rupture or aneurysm, which are not listed here. So if there is a weakening of this wall, there will be a rupture of the wall, then the blood goes outside, or there will be a partial rupture which is not complete, causing an outputting here, which is called aneurysm, as you have seen in the general pathology. So other complications are calcifications, of course. And as you understand, when there is a plaque rupture, the problem is that if there is a detachment of that rupture, that plaque will go on with the blood. So meaning that the blood will go with a small solid component from the plaque, from the atherosclerotic plaque. So in that case, also the person will have atherosclerotic embolism. So, and as you have seen, embolism, we have many types of embolism. We have this thromboembolism, atherosclerotic embolism. We have gas embolism. Gas embolism, it means gas can enter into the blood, and that is very dangerous. That's why when you are taking blood, for example, sampling blood from the veins from a patient, or if you are giving intravenous infusion, what you call serum or transfusion and so on, make sure no air bubble enters into the infusion, because that air bubble, you can feel it is just a simple thing. When it enters into the bloodstream, it will be considered like a solid thing, and it will occlude the blood flow somewhere. So be very careful with that, and supervise well the nurses, because as medical doctors, you will be most of the time bosses, but you will have to make sure the nurses do things rightly. So if the nurse gives a transfusion or perfusion, make sure there are no air bubbles inside the infusion. And air bubbles usually they come when the serum is finished, and then you don't close the flow. So in that case, the air will go into the bloodstream of that person, and the person can die. The people, they ask themselves what happened. So another cause of embolism, as we have seen, is amniotic fluid during delivery. It is an accident. Nobody knows how it happens, but an amniotic fluid can enter into a vein, into veins. in the cervix and or uterus, and then that amniotic fluid will go through the vena cava, then to the heart. The heart will usually pump it towards the lungs, and then the person will experience pulmonary embolism, and it is a very dangerous. At least I know some people who have experienced that, and they are still living. So it is like a miracle, but they get treatment for months or years. So that is, and another type of embolism we have seen is the fat embolism. So fat embolism happens usually when there is a fracture of a bone. You know that in the bone we have bone marrow, and the bone marrow is rich in fat. So if there is a fracture of the femur, for example, is the most common cause. So the fat from the bone marrow will enter into some veins, and then it will cause embolism somewhere, usually into the lungs, of course. So I was explaining the issues of this atherosclerosis and its complications. Then these are structural things that you see. So clinically, what will happen if it is the heart? The part of the heart which was supplied by that blood vessel will undergo myocardial infarction. In the brain will undergo cerebral infarction. Gangrene, if it is just an artery going or supplying these parts, these tools. Then another complication can be abdominal aortic aneurysm. So you see that here there is a pocket which is formed. And when there is the abdominal aortic aneurysm, it almost always happens just before the bifurcation of the aorta to these iliac arteries or femoral artery. So nobody knows why it always happens here, but this is just an observation. Usually it happens there. So, and I remember when I was working in a district hospital, we were doing surgery. I don't remember what was the reason, if it was a cesarean section or not. That when you are doing it, you could feel that behind the intestines there was a pocket which was pumping together with the heart. So we said this is likely to be an aneurysm. So we did what we could do, and then for that aneurysm, it was beyond our control. So we sent the patient to teaching hospital so that they diagnose it, because we didn't have any method. And we could not see it because this is a retroperitoneal, and for us we are intraperitoneally doing surgery. So this was retroperitoneal, could not go there. As a general medical doctors, we are not specialists. And here you can understand why, for example, if a patient, they can tell you, and you know, maybe in some families, people with cerebral infarction or stroke, you can understand why sometimes they have a paralysis in some parts, not the whole body is paralyzed. It is because the infection will take just a part of the brain, not the whole part. So if the infection is too much, the patient usually dies automatically. But if it takes a small part, you can see someone having paralysis, maybe fascial paralysis, and in that case, usually the patient doesn't talk, or the patient can have paralysis of one side, what you call hemiplegia, so paralysis of one side of the body, right side or left side, and so on. So, any questions so far?
This question.
Yes.
I'd like to ask that when someone has an infection, maybe a myocardial infarction, what is done to release that, or that person is going to die?
You mean what to do to prevent the death?
Yes, prevent the death of the person that has myocardial infarction.
So what can be done? There are things, we shall see some of them. There is, for example, arterial coronary artery bypass surgery. Bypass surgery, it means there is somewhere, you know, there has been occlusion. So what you can do is to put an artificial artery, a part of the artery, to connect the normal part before the occlusion and the next normal part, which is not infected. So it is a bypass. I think we will see some pictures, some diagrams after explaining that how that is done. But usually the interventions happens when there is ischemia before myocardial infarction takes place. So when there is ischemia, when the patient experiences ischemia, they can do that bypass. They can do ballooning. Ballooning, it means you send a catheter through the blood vessels until it reaches the heart, and then when it arrives where you want to intervene, then that tube will have a balloon in its wall. So you will pump an air or gas. So when you pump it, it will cause a dilation of the vessel which was occluded. So if you have seen how the catheter, urinary catheter works, as you know, you insert the catheter. When it arrives inside the urinary bladder, then you pump an air through a balloon which is on the catheter. So when you pump it, that balloon will enlarge, and then it will prevent the catheter to come back. So for the heart, the balloon will help to dilate that vessel. Of course, these are procedures which are not done everywhere because it requires a state-of-the-art technology infrastructure that we don't have in most of our developing countries. So otherwise, when you know that this is caused by thrombosis, what you can do everywhere, even at the health center or on the street, you can just give medications to that patient, a medication to dilute or dissolve the thrombosis, the clot. But that is when you know it is caused by a clot. But if it is caused by atherosclerosis, you can't do much. But there are some interventions which can be done. We shall see them afterwards. So in brief, I can say that when there is a myocardial infarction, what is usually done is just supportive treatment to that patient, because you cannot reverse that. But when it is still ischemia, then you intervene to avoid or to prevent the occurrence of infection. Okay, is that fine?
Yes, that's fine.
Okay, thank you.
Question.
Yes?
I need more clarification about pulmonary embolism.
About?
Pulmonary embolism.
Pulmonary embolism. Okay, pulmonary embolism, but you know what is embolism?
Yes.
So pulmonary embolism, it means there is an occlusion of blood vessels of the lungs. And these are the vessels which are coming from the heart. And you know, the right heart, the right ventricle will pump the blood towards the lungs, so that blood receives oxygen from the lungs. So the pathophysiology of it, of course, it will depend on the cause. But the main pathway is that there will be something coming through bloodstream, reaching the right heart, and then being pumped to the lungs. That can be a blood clot, which is a thrombosis. In that case, we will say the thromboembolism. So the pulmonary embolism caused by thrombosis or caused by thromboembolism. This can be a fact. If, for example, a person has experienced a fracture of the femur bone, then the fat of the bone marrow will enter let's say the femoral vein, then comes through the inferior vena cava to the right heart, and then the heart will pump it towards the lungs. So it can be caused by the gas. If you give a perfusion, and in perfusion also there are air bubbles. It can be amniotic fluid in the case of a mom who was delivering. And the main problem is that the lungs will suffer much. The patient will experience an intense pain. There will be intense pain, usually followed by edema into the lungs. So the breathing will be almost impossible. So these are the patients who will need support, so respiratory support and so on. So it is really an emergency, extreme emergency. Whenever you think a person is having pulmonary embolism, it is an extreme emergency. And usually the treatment will be medical in our cases. In other areas, it can do surgery. So when the embolism is very large, for example, a very large blood clot, it would require to do surgery. It will be required to do surgery. Otherwise, if it is a large blood clot, you can give a treatment, and when you give a treatment, that blood clot will be dissolved into very small clots, and then you can say that the problem will be not solved, because if there are small blood clots, they will enter into now very smaller pulmonary arteries. So problem persisting. But if you are lucky, you can give a treatment, then the clot, if it was not too large, it will dissolve completely, and the patient will be cured. But usually they take there's a drug for a long time. So the drugs which are very simple to dissolve clots, just aspirin is one of the drugs which are given. So you will see that patients having who have undergone the cerebral infarction or stroke, you will see that most of the time they give them aspirin, but you will be very careful. Stroke can be caused by hemorrhage or clot. So if it was caused by clot, to give aspirin is right. But if it was caused by hemorrhage and you give aspirin, you will increase hemorrhage. So you must know the cause of the stroke. If it is hemorrhagic, don't give aspirin. If it was thrombotic, you can give aspirin. So that's how procedures are done. So that's why I was saying you can intervene whenever you think someone is having an embolism or thrombosis. You can intervene anywhere, because I think aspirin is found even in the health centers. So is there any other question? Okay, so we can proceed. So it was like a general presentation. Now we start to see some more details on the ischemic heart disease. So you will understand that if we say ischemic heart disease, it combines both ischemic or angina pectoris and then myocardial infarction. Yes, question?
Hello?
Yes.
I have a question. How can patient with diabetes result in ischemic heart disease?
With diabetes result into ischemic heart disease?
Yes, how?
Okay. We shall see. So what I can say here is that as you know, in diabetes there is increased glucose content in the blood. And one of the consequences is that these patients usually they experience vasculopathies or vascularitis, meaning inflammation inside the vessels. And when you talk about inflammation inside the vessels, you will hear that one part which is affected is the endothelium. So endothelial cells and the endocardial cells, they are the same. The difference is the location. So diabetes will cause lesions it causes lesions into the small blood vessels and some large blood vessels, especially the endothelium. So when these lesions are there, they can happen even inside the coronary arteries. So if it happens inside the coronary arteries, the lesion of endothelial cells, as I said,
We can't hear you, Prof.
okay. So I was accidentally muted. So I restart.
Yeah,
I
maybe.
was saying that I started responding to that question. I was saying that the diabetes, as you know, is a disease in which we have increased content of sugar, especially glucose inside in the blood. So one of the consequences of the increased sugar is to have lesions or injury to the endothelial cells. And in diabetes, if you read about the pathogenesis of the diabetes or the consequences of it, you hear that usually in diabetes patients, they have small vessel vascularitis. And if that vascularitis takes place inside the coronary artery branch, any coronary artery branch, then a lesion to the endothelial cells, as I have said when we are starting, is usually followed by a blood clot being formed there to prevent hemorrhage. But when that blood clot enlarges, it will be a thrombosis, or will last for a long time, it will be a thrombosis. So it will be a thrombosis originating from the coronary artery itself. So we cannot call it thromboembolism because it originates in the same coronary artery, occurs the same coronary artery, and then the patient will experience the infarction of the part which was supplied by that coronary artery. So that is how I can explain how diabetes can cause ischemic heart disease, right, or can cause even a brain infection or a stroke, or can cause gangrene of the limbs. And this you will see, it is not just a theory. You will see patients with diabetes that some of them, they have their limbs or their toes or fingers amputated or removed. It is because there has been a gangrene caused by thrombosis and the infection of the tissues, which was irrigated by these vessels. So it is a common thing in diabetic patients. So here we have, we say that ischemic heart disease is a very common health problem. So maybe previously people used to think that it is a disease of developed countries, but the issue was that for them they could diagnose. For our countries, we could not. So in this hospital, when they bring a patient, a dead body who died abruptly, usually you will say the cause is not known. So, and the family members will be happy, not happy. They will be just satisfied, they will go and bury the dead body. But in other countries, they can't do that. They will have to know the cause. So they do autopsy, a clinical autopsy usually, to know the exact cause of death. So it is most of the cardio infection cases that they are diagnosed after death in our areas. But in developed countries, they can do it even before death, they can intervene and so on. So otherwise, you will hear that most of the deaths in the developed countries are caused by this ischemic heart disease. And maybe, of course, I can agree that they have more prevalence of that compared to our countries because of their lifestyles. So the lifestyles in the developed countries, you do everything seated. You don't use physical energy to walk or to work, and therefore that lifestyle predisposes them to develop, to be obese or to have too much fat in their bodies. And having too much fat is a risk factor to atherosclerosis. And also they eat fatty things, meat and so on. Or they will predispose them to having atherosclerosis, which is the very common cause of ischemic heart disease, as you see on this slide. So in summary, I can say that this is a very common problem in developed countries. It is most likely also common in our countries, but not as common as in developed countries. So as I said, there are two main diseases or types of ischemic heart diseases. One is angina pectoris, as I explained, which just means ischemia, or there is a reversible cell injury. Then there is MI or myocardial infarction, which is already there is irreversible death of the cells. So these factors are listed. So hypertension, also the pathophysiology of having ischemic heart disease caused by hypertension is almost the same as diabetes. Hypertension also causes a lesion or injury to the endothelial cells, followed by the thrombosis and so on. But another way is that hypertension usually in some cases follows atherosclerosis. Yes?
Excuse me. Ngira ngo nari nasigayeho kubera ko ngira ngo sinzi ukuntu byari byagenda, ariko nari mfite ikibazo kuri how diabetes causes the heart diseases. Nagira ngo mumbwire ni gute.
But it was what I explained.
But I didn't get it where ukuntu increase of glucose in the blood will cause the atherosclerosis. I didn't get it where. How the increase of glucose in the blood will cause the injury of endothelium or endocardium muscles.
Okay. Because I can't get you. There is a noise around you.
No, not the one.
Okay, there is too much noise there. I could not hear you after. But what I had is to ask why diabetes causes.
Are you getting me now?
Yes. Yes, you can go on. Okay, maybe you are done. So I was saying that the content of the blood it matters very much. The content of some chemicals, it matters much. So if there is increased sugar, it will cause lesions to the endothelial cells. So if you want to go into the pathways, I will not explain here, but you can read in two books of biochemistry how that can happen. But increase the sugar or increase the fat and so on, or they cause lesion to the endothelial layer of our blood vessels. So with that, then there is a starting of blood clotting, which can result into thrombosis. So that is in a simple way I can explain the occurrence of ischemic heart disease or even gangrene to the peripheral parts of our body or stroke in cases of diabetes mellitus. So it is like a smoking. So you cannot explain how just in logically how smoke will cause tobacco smoking will cause atherosclerosis or ischemic heart disease. The explanation is the same. It is because in the tobacco smoking, there are chemicals which go into the blood and they will cause lesions to the endothelial cells. So there's a patient who will have a lesion not only into the coronary arteries but also any other vessels, therefore causing infection in the areas supplied by these vessels. So lifestyle here, it is a risk factor, lifestyle, because it is a lifestyle causing someone to have either it be obesity or causing diabetes and or causing hypertension and so on. So lifestyle here, you must understand the context of it. It is a lifestyle that promotes either diabetes or hypertension or any other hypercholesterolemia status. So the same diet, so you eat too much fat and less fibers or antioxidant, then you are at risk of developing atherosclerosis or thrombosis because of what I explained. Another factor is genetic. There are some people who are predisposed to that. So in their families, maybe they are predisposed to develop diabetes or they are predisposed to develop hypertension, and then as a consequence, ischemic heart disease. So, as you know, hypoxemia is a diminished transport of oxygen by the blood. And this you have seen in the general pathology, especially in the course of in the chapter cell injury. You have seen that hypoxemia is not as dangerous, as much as dangerous as ischemia, because in ischemia you have cut of both nutrients and the oxygen, while in hypoxemia there is a cut of oxygen alone. So ischemia is more dangerous. So it is a ischemic heart disease. Some they call it also coronary artery disease or coronary heart disease. So it will depend on the book you are reading. But ischemic heart disease, these are syndromes. So you cannot say the patient has a diagnosis of ischemic heart disease. You know, maybe I don't know if you have seen the course of the module of signs and symptoms or symptomatology. But you know, what is a syndrome? So a syndrome is like a set of signs and symptoms which can refer to different types of diseases. For example, if there is what we call in French syndrome paristre. It means like a malarial syndrome. It looks like a malaria. It doesn't mean every patient with malarial syndrome will be having malaria. So it will be composed by pain, by headaches, fever, vomiting, sometimes abdominal pain. So when you have a patient with that, as a general medical doctor, you will say this patient has a malarial syndrome. So therefore, what are the possible diseases that result in a malarial syndrome? So the first one, of course, will be malaria. Another one will be typhoid fever. Another one can be viral infection, and so on. So after having there's a differential diagnosis, then you do investigation to have a final diagnosis. So I say this to explain syndromes here. So when you have given this conclusion, this patient have an ischemic heart disease, don't be satisfied by you have diagnosed the disease, not. You have given a syndrome, now request for further investigations to have a final diagnosis, because the final diagnosis will determine which treatment to give. So here they say that this is the rate manifestation of coronary atherosclerosis, the ischemic heart disease. We shall see why they say here rate manifestation. But as you understand, it is rate manifestation because atherosclerosis starts as just a fatal streaks which cannot cause signs or symptoms, but as they develop as atherosclerosis, evolves or enlarges, it will cause symptoms when it occludes or suboccludes a coronary artery. So that's why they say late manifestation. So early manifestation of atherosclerosis, they are not there. If it is just a fatal streak, there will be no clinical implications of that. So the causes, they say ischemic heart disease is at 90% of the cases caused by coronary atherosclerotic arterial obstruction, as we have seen in some diagrams. So there are 4 main types of ischemic heart diseases. There is myocardial infarction that we have seen, and there is the angina pectoris. So these are the main ones. So another one is sudden cardiac death. So unfortunately, this is an accepted diagnosis. And you see that it is given when someone has died. So it means the person dies, you have run or will run this in a course of forensic medicine. A sudden cardiac death, it means someone has died within 24 hours of onset of symptoms, and you don't know really the real cause of that death. It is in that case that this diagnosis is given. So usually it is given by forensic people, forensic medicine specialists or forensic pathologists, or any a general practitioner who does autopsy. So another one is chronic ischemic heart disease with heart failure. So there are people who have heart failure caused by ischemic heart diseases. But of course, there's usually in our areas there are few. But here you understand, if it is chronic, it means it came slowly. So these are people who will have a very small myocardial infarction one day, another day they have another small myocardial infarction which doesn't cause death or very severe pain. So at the end, they have their most of their muscle infected, but so that the function of the heart pumping the blood will be greatly affected. So it is a heart which can pump a blood, but at a very unsatisfactory way. So we shall see more details after. So acute coronary syndromes, these are important. The important predisposing factors are plaque disruption or acute plaque change. So we shall see what is the meaning of this. Acute plaque change, there are somewhere I have shown them. They are a plaque rupture or hemorrhage. If there is a plaque rupture or plaque hemorrhage, these are what we call acute plaque change. And here you understand plaque here refers to the atherosclerotic plaque. And these acute coronary syndromes, they are acute myocardial infarction. It means the person undergoes ischemia and automatically infarction. So usually here you can't intervene to prevent the infarction. So they are very quick. There is unstable angina and sudden cardiac death, as I explained before. So Angina pectoris, it can be stable or unstable. We will see the difference. But the unstable angina, it is caused usually by changes inside the plaque, either disruption or hemorrhage. So we shall see more details of that. Usually it is said that ischemia happens if there is a stenosis of at least 70% of the caliber of the coronary artery or any other vessel. So meaning that if the coronary artery is occluded at 50%, usually there are no symptoms on rest. There are no symptoms on rest. When the patient or the person is resting, there are no signs or symptoms, no pain. But when the person is doing exercises, then the pain can happen. Can happen if the stenosis is at 70%. So even at 50%, no pain will be there. But here we are discussing about stable angina. stable angina. For unstable, we'll come back on that after that. So briefly, in stable angina, meaning without a plaque disruption, the signs and the symptoms of ischemia will happen if there is a stenosis of 70%, 75% of the caliber, and the person is doing exercises, or you are just, for example, you are carrying a heavy thing. Then, in stable angina pectoris again, the patient will be symptomatic at rest when the stenosis is at 90%. So this means if you are in a district hospital where you cannot do much investigation, and the patient experiences signs and symptoms that you diagnose as the angina pectoris, if you tell that patient, if you put that patient into rest conditions and the pain disappears, you will understand that this was most likely a stable angina caused by occlusion of the coronary artery, but at less than 90%, between 75% and 90%. But if the patient is resting and the pain continues, you'll understand that the stenosis of the caliber is at 90% or more. So in that case, you will decide what to do. And usually this will need the surgery. You will have to send the patient to teaching hospitals. So the pathogenesis is that there will be decrease in coronary perfusion relative to the myocardial demand. So if someone is resting, the myocardial demand will not be high. But if you are doing exercises, then the myocardial demand will increase, and therefore you would need more coronary perfusion, but which is not possible because of the stenosis. So now for the role of acute plaque change, which are defined as when there is ulceration, erosion, hemorrhage, rupture, or fissuring, or thrombosis. Or these they define acute plaque change. Now their problem is that even when the stenosis is less than 75%, if there is acute plaque change, the signs and the symptoms will appear. Because the stenosis here, it is about the atherosclerosis. If there is thrombosis which is added, then the occlusion will be more than 75%. And here again, they're saying the role of inflammation. Here they say the role of inflammation because when you take a tissue biopsy from the area of atherosclerosis, you will find a lot of T lymphocytes or T cells, a lot of macrophages, and in these patients they have what we call C-reactive protein. This is a protein which is increased in the bloodstream, in the serum or plasma when there is an inflammation somewhere inside the body. So it is an investigation, maybe not done in the district hospitals, but in the teaching hospitals they do, I'm sure. In the district hospitals, I'm not sure. It is when it is not done, you can do other tests such as Retrosite Sedimentation, what you call in French the vitesse de sedimentation. So these they have been seen to increase when someone is having infection or myocardial or ischemic heart disease. So meaning that's why they mean that in ischemic heart disease there is a big role of inflammation. So the role of coronary thrombus is demonstrated by the fact that usually in most of atherosclerosis cases with ischemic heart disease, when you do autopsy or surgery, you find that there is a thrombus inside there. So, and you see it here. So you see that the wall here on the upper part was thin, but on the lower part is thicker, meaning that here there was atherosclerosis, and there is a fissuring here. Fissuring, or a kind of rupture, which has caused a hemorrhage and then a thrombus. So also there is a role of vasoconstriction. Vasoconstriction. This is seen because there are platelet and endothelial factors which are observed to be increased when there is a ischemic heart disease, and some of these factors, they are responsible for vasoconstriction. You have seen in the in general pathology that there are factors for in inflammation, I mean, mediators of inflammation. There are those which cause vasodilation, such as histamine and the others, but also there are others which cause vasoconstriction, and they are seen to increase in the cases of ischemic heart disease. So this is diagram. Yes.
Yeah, on the previous slide.
Mm-hmm.
Yes, I'd like to ask. I don't understand what acute plaque change means.
Okay, to understand it, there is a patient have atherosclerosis, and the vessel is occluded, let's say, at 50%. In that case, to understand that the patient will not have any sign or symptom, because even when he is exercising, the stenosis will not cause signs or symptoms of ischemia. But when there is a change, there's an acute change. There are changes which happens and it automatically will cause acute signs of and symptoms of ischemic heart disease. And there's ones that are ulceration. So they are acute. I think acute, you understand the difference between acute and chronic. It is something which comes abruptly and usually causes very intense signs and symptoms. So there's acute plaque changes. There are changes which will happen to an existing atherosclerotic plaque. So they include erosion, meaning that there will be a removal of let's say, endothelial cells. There will be ulceration when there is endothelial cells are removed and maybe a part of lamina propria. Then there is hemorrhage into the atheroma itself, not hemorrhage towards the blood vessel, lumen, but inside the atheroma. There is a rupture. Rupture, it means it is like a fissuring, but fissuring is more simple than a rupture, because the fissuring, when there is a part of the atheroma which is removed after fissuring, you will say there is a rupture. Or there can be a complete rupture of a blood vessel wall. Another change is the thrombosis. So I don't really understand your problem, but these are things which come abruptly to a pre-existing atheroma, and they will cause acute symptoms of ischemia. So that's why they are called acute plaque changes. So the plaque is already there, the changes are acute. Is it fine? Okay, let's assume so. And on this diagram, we'll maybe understand more. So for the histology of a vessel, you know that there is a lumen followed by tunica intima, and the tunica intima is composed of two things, as you know. There is the endothelium and then a lamina propria. We have a tunica media and a tunica adventitia. So if there is atherosclerosis, you have seen in the general pathology that atherosclerosis starts in the tunica intima, just beneath the endothelium. So here you see that the endothelium, we can guess it is this black line. So beneath it, you have this atherosclerotic plaque inside the lamina propria of the tunica intima. So in it, you have repeats, because almost always this starts with repeated position. You have seen or you have read in atherosclerosis that the pathogenesis of there are two schools or two kinds of thoughts about this. So some they say there is first an injury to the endothelial cells, and the injury then will cause blood clot to happen and a reaction, inflammation to happen. And that inflammation will cause macrophages to come. When macrophages come, they will kill some cells. And when it's macrophages kill and T lymphocytes kill some cells there, the dead cells, you understand, they have, so someone is causing echoes. So T cells and macrophages will kill some cells, and when a cell is dead, you understand, it has a fat in the phospholipids membrane. These fats will react with calcium, and then causing calcifications to come. When there is a calcification with cholesterol clefts, themselves, you have seen that they appear as needles. There's the needle, they cause more lesion around. When it causes more lesion, there is fibrosis coming in. So when the fibrosis comes, then you have a large plaque. So that's how some they explain that it is caused by first the injury to the endothelial cell. Other scientists say no. The atherosclerosis starts when someone is having too much fat going through the bloodstream, and that fat goes to the tunica intima by just diffusion without injury to the endothelial cell. And when it arrives there, then it will activate this inflammation, as I explained it, and which will cause an injury to the endothelial cells and the other cells, and including tunica media, then causing the plaque, as I said. So some they think it starts with inflammation and lesion to the endothelial cells. Others they say no, it starts with cell injury inside the tunica intima. But at the end, in our cases, we have lesions of endothelium and the deposit of lipids, of cholesterol clefts, of fibrosis inside the tunica intima. So here we have what we call fixed coronary obstruction. It is fixed because this cannot be removed by medications or by any other methods. It is there. So this can cause a typical angina or stable angina. Stable angina. Because of the occlusion, and that can be the extent of having that. It will be in function of the exercises someone is doing and the caliber obstruction. So therefore, it is where here we said if the obstruction is at 75% or more, there will be no sense of the symptoms at rest. But if someone is exercising, then the symptoms will appear. But when the obstruction reaches 90%, for example, in this case, 90%, the person will have pain even at rest. And then here we have plaque changes are starting. It can be platelet aggregates. And then when the aggregate, as it grows, the aggregate grows, we'll have a thrombus. The thrombus can occlude completely the plaque. But as you see, this plaque is of the same size as here. So meaning that here, this patient could not have pain because it is less than 75% and there are no changes. But because there is another thrombus, which is an acute change, this patient will experience pain even if the plaque itself was at less than 75%. So the pain here will persist even at rest. But how, as a medical doctor, will you differentiate between this, the severe fixed coronary obstruction, and the occlusive thrombus? Clinically, how will you do it? We will see it after. There are medications which will help you. So at least here we will know that it is not a stable angina at at less 75, at less than 95%. That will not, you will know. But you will have to add drugs for you to diagnose what is the real cause. Is it a severe fixed coronary obstruction, or it is an acute change on pre-existing atherosclerosis? So you see that this and this, these two, they are considered as acute coronary syndrome, these two, because they are the syndromes are themselves are caused by these added changes, not by the plaque itself. So, yes?
We can't see your cursor.
Sorry?
Your cursor of motion.
My cursor is not working. Do you
Yes.
see it? Okay. So, but I think you understood. Here, the two lower figures, they are the ones explaining the acute coronary syndrome, because they are caused by an acute plaque change, which is here an example of thrombus. It can be any other acute change like those we listed. We listed the fissuring, the rupture, and so on. But here the example given is a thrombus. So I was saying that this plaque itself could not cause ischemic heart disease, because its extent is less than 75%. But because there is an added thrombus, automatically it will cause acute coronary syndromes. So ischemic heart disease in general, here we have the syndrome, we have a stable angina, unstable angina, transmural myocardial infarction, endocardial myocardial infarction, and sudden death. So I think here you see that this is just an issue of anatomical location. Transmural, it means something which includes the whole thickness of the wall of the myocardium. While the stable endocardial myocardial infarction, it means there is infection of the myocardium, but just a small part directly next to the endocardium. So here we have a syndrome. We have the degree of stenosis, the existence of plaque disruption, and the plaque associated thrombus. So you see that in stable angina, we have a stenosis of more than 75%. And it is here that you have seen that this patient, if he does exercises, he experiences pain. If that pain comes only when he's exercising, you will say this is a stable angina, and it is most likely a stenosis between 75% and 90%, because as you have seen, when there is a stenosis at 90%, the patient will have a pain even at rest. So as a clinician, it will be very easy to say this is at least a stable or unstable angina, or it is a stable but less than 90% of the caliber. So in stable angina, we don't have acute plaque change. So no plaque disruption or thrombus. So no associated thrombus. So these are characteristics of stable angina. For unstable angina, the stenosis can be. So someone is talking. Can you mute yourself? So it means there are some people who are just doing their businesses. So we shall see. So for unstable angina, the stenosis can be of any degree. For example, in the previous picture, we saw here the stenosis is not is maybe 50% or 60%. But because there is a thrombus which came in automatically, it was symptomatic. So the stenosis can be variable, 70%, 20%, 40%. So the issue here will be the plaque disruption. And if there is a plaque disruption, of course, if you do surgery, you will not find it where there was a plaque, because it will have gone somewhere else to occlude the further, not at the site of thrombosis. So these are the patients who will have a thrombus, but which is not occlusive. Why? Because if it is occlusive, this patient will die. No, not will die. The tissue will die. So the patient will have myocardial infarction if it is completely occlusive. So if there is a transmural myocardial infarction, the stenosis is variable. It can be 20, 40, 60%. There is also frequent plaque disruption, and there is occlusive thrombus. For this endocardial myocardial infarction, they are almost the same as transmural, but the thrombus is variable. It can be not occlusive or occlusive. So here it depends on which part of the coronary artery which is affected. If it is the part which irrigates just the subendocardial myocardial infarction, it will die alone. But if it is a vessel which irrigates the whole thickness of the muscle, then we have a complete myocardial infarction. So sudden death, you see that it is caused usually by a severe stenosis. So here it means it is someone who had a severe stenosis, let's say at 90%, and there is an added thrombus or plaque disruption. So these are patients who will have a sudden death. So this is the realization. So it means there has been a collection of data from all the cases. So this is what they found. They found that most of the sudden cardiac death, people, they had a severe stenosis. Most of them have plaque disruption, and some they had thrombus, but which is usually small. So these are observation from the data from the clinical or autopsy services. So angina pectoris, these are signs and symptoms. Chest discomfort. So these are people who have pain in the chest, of course, because the heart is in the chest. It is prolonged, recurrent, and of different qualities. So some patients would say, I have pain, but maybe it irradiates. You know the meaning radiation. Birandira hano kigashora mu kuboko, kigashora mu ruti rw'umugongo. Yavuze gushora, as a medical doctor, understand irradiation. So there's a pain irradiating too. So you know that I think you have seen this in this signs and symptoms. When there is a pain of the heart, it irradiates toward the left upper limb. So aribwa mu gatuza, ariko uburibwe bukaba irradiatinga mu kuboko kw'ibumoso. In a difference to some other diseases. For example, uribwa igifu bimurira mu gatuza naho hejuru, ariko irradiation itijya mu mugongo. So there are some differences. So, and I remember when I was doing my internship at Ruhengeri Hospital, there's a day we received a patient. She was a university student. And she said she was saying I have a pain in my heart. So it's as if she was saying she has ischemia. That when you could ask her where does the pain irradiate and so on, you could find that it is not just an issue of heart. It was just an issue of a stomach. So she has a gastritis. And also, when I was there, I once received the patient. He was a man who had a wedding that day. And then when they were in the church, he developed a very severe pain, upper epigastric pain toward the chest. And then he was somewhat resilient there until the end of the church services. And then when they went to the reception area, then he could not continue to withstand that. Then they decided to bring him to the hospital. So he he had a severe pain. His mother was crying that some people have poisoned him. So he came with many people who were in that wedding ceremony. So they are saying he poisoned and the heart, he has a heart attack and so on. So it was night. So I received him, I examined him. I just found it was just a gastric pain. So I told him this gastritis with ulcer. So I told him, so I think the issue was you had a stress, and you know a stress can cause an ulcer in just a few minutes. An ulcer in a person who had never had a gastritis. So I gave him a treatment, perfusion, and so on. And in the morning at 4 p.m., he was just very happy. He had the phone. He was calling the family members that he is very fine now. The feast of the marriage should continue. So it means you don't have to be misled by patients or their families when they come and say I have a pain in the heart or heart attack. So you must know how to examine and diagnose. So because they have a chest discomfort, you can think it is heart, but usually it is just a stomach issue because they are organs which are contiguous in the same area. So their pain irradiates in different areas. So the angina pectoris, anybody can experience a pain in the chest, and usually because any person can experience a very transient ischemic reaction in the heart. But it doesn't mean this is an angina pectoris. To say it is angina pectoris, this must be prolonged and recurrent. So meaning that the pain comes, it takes minutes, and then it is relieved, and it comes again, and so on. But if it is a very transient pain in a few seconds, this happens to anybody, especially people with hypertension. They used to have these pains just in a few seconds, and then it goes. So that cannot be called the angina pectoris. So the cause is the transient myocardial ischemia, seconds to few minutes. So the patterns are stable. If 75% of the vessel is blocked, and usually it will be transient, less than 15 minutes. This will be aggravated by exercises and relieved by rest and nitroglycerin. This is a vasodilator drug. So this is why I said there is somewhere you would need a drug for you to diagnose. So don't think that the drugs are given only to treat. There are many times you diagnose a disease using treatment. So you treat, and then you find the result, and then you decide this was or was not a disease. And so, for example, if you are working in a district hospital or health center, and you have a patient having a syndrome of looking like malaria, you think of malaria. You also think of, let's say, typhoid fever. And at that health facility, you don't have a method to diagnose typhoid fever. So what you will do is to give a treatment for malaria. And if you find that the symptoms and the signs are not changed within a given time, let's say 6 hours or 12 hours, then you will say, and of course, in that case, if you have you have a lab which can diagnose malaria, you will do it. So the laboratory test says negative for malaria, and the signs of symptoms, of course, persist. Then you will say, so probably it is typhoid. We can't diagnose it, but let me give it the drugs to treat typhoid. You give them. Then the signs and the symptoms of typhoid fever disappear. If they disappear, you will have to diagnose this was a typhoid fever, and you diagnose it because it responded to the treatment. So the same here, nitroglycerin is a drug, a vasodilator, meaning that it will try to increase the caliber of the stone of the area which has stenosis. And if you give it and the pain is relieved, then you will say this was a stable angina. There is what we call Prinzmetal Angina Pectoris. There is a coronary spasm, meaning there is a contraction. It's a very tough contraction of the muscle on the coronary artery. It is episodic, and if you do electrocardiogram, of course this is done in a few hospitals, you will see the typical change for Prinzmetal Angina Pectoris, which are ST elevation, and this will be relieved by nitroglycerin, but not rest. So you see, here there is a relievement of the stringent symptom by rest and nitroglycerin, but here only nitroglycerin, but not rest. So this only alone can help you to diagnose this was a Prinzmetal angina pectoris or it was a stable angina. So meaning that you will put a patient at rest first. If he responds, then it will be a stable angina. If he doesn't respond and you add nitroglycerin and then it responds, you will confirm it is a Prinzmetal. For unstable angina, either there is a 90% of the vessel which was blocked, and usually there is an acute plaque change on a pre-existing angina, a plaque which can be even less than 90% of occlusion. It will be prolonged and it will be not relieved by rest, vasodilator, and you will understand that if it cannot respond to rest and the drug, you can do more at district or a district hospital or health center. So usually these are the patients who will progress to angina. So that's why this angina pectoris is called pre-infarction angina. So I mean, most of these patients will progress to the infarction, not to angina, because they have already angina. So for the myocardial infarction, as I said, there is a transmural. You see that this is a whitish area. It is the infected area, and here you see that the infected area is just a small thickness just beneath the endocardium, because this is the endocardium, myocardium, and then pericardium. You see the coronary artery here, and it has a black thing in the lumen. This is the thrombus. So this is a diagram. It is not a true picture, of course. It is a diagram to show that when there is a thrombus here, we can have infarction just on a small thickness behind the endocardium, or we can have a transmural infarction. And here, as you understand, there is a full thickness involvement. There is a superimposed thrombus in the atherosclerosis, and there is a focal damage in the myocardium. For subendocardial myocardial infarction, it affects 1/3 to one-half of the ventricular wall. There is a decrease in the circulating blood volume. This is the main cause. Decreased circulating blood volume, such as patient with shock, hypotension, or raised thrombus. So this is circumferential. It means when it happens, it takes a large area, like the whole circumference of the ventricle, but it doesn't take the whole thickness. While the transmural one, it is focal. It affects a small part of the myocardial infarction, but the part which is affected is completely or transmurally infected. So you understand that both of them are dangerous. This is dangerous because it affects the whole thickness of a focal area. This is dangerous because although it doesn't affect the whole thickness, but it affects a large area. Circumferential meaning that it affects the whole circumference of the tissue around the endocardium in the ventricle. So as we said, we saw before, myocardial infarction is also called heart attack. So the incidence is that it is a disease of older people. This is what is said, but it can affect also younger people, especially those having obesity and so on, diabetes and so on. So usually it is said that now 45% of all the cases, they happen in people aged 65 years and above. So in young people, it is seen that 10% of the patients are in their 40s, 40 years up to 65, of course, because 40 others are there. So in summary, young people affected are less in numbers or in incidence as compared to elderly one. So for sex, it affects more male than females. I think this you have seen also in atherosclerosis. And there is no true explanation pathophysiologically how this can happen. So maybe females are protected by some hormones such as progesterone, nobody knows. But at least it is known that when the females reach their age of 55 and so on, so when they are already menopaused, the risk is almost the same as males. So meaning that maybe they have been protected by some of their hormones. So for ethnic, there is no difference between blacks and whites. I think these terms, you will see them in most diseases, in cancers and so on. So when you say Africans, they mean blacks. So here they are comparing Americans who are black and the Americans who are white. So the risk is the same. So the risk factors, there are modifiable one. The modifiable one is diabetes mellitus and the hypertension and the smoking. So meaning that these are the things you can control. So if a patient has diabetes mellitus and you control the blood sugar, it becomes normal. Even though the patient continues the treatment, but the blood sugar is normal. In that case, you will prevent the happening of this disease. The same for hypertension. If it is well controlled, then the risk of having the ischemic disease will go down. So another thing you can control it is smoking and the cholesterol content into the blood. So it is why you will request your patient to change the lifestyle, to do exercises, to control diabetes or hypertension, and then to take vegetables, fruits, and avoid or decrease the fat intake. So for the pathogenesis, the coronary vessel, there will be a coronary vessel occlusion, which is caused mainly by atherosclerosis, as we said. In other cases, it can be caused by vasospasm. So vasospasm, umuntu agira ngo agize imbwa mu maguru, ni spasm bije muri muscle. So it is something you cannot control. So when it happens, you must intervene, but there is no known way of preventing it. So the most important mechanism is dynamic changes in the plaque, rather than the plaque size. I think this you understand, we have explained much about this. So the main issue is the plaque changes. Because if there is a plaque disruption, there will be platelet aggregation, there will be formation of a thrombus, and then we have a vasoconstriction, which happens in a few minutes. So when can you reverse ischemia so that myocardial infarction doesn't happen? So it is written here. Around 20 or 30 minutes with ischemia, already the myocardial infarction will be there and no further intervention. So meaning that if the patient has a myocardial, has a angina pectoris, you must intervene within these few minutes. So this is because if there is a ischemia for more than these minutes, the ATP production will be less than ATP, the adenosine triphosphate will be decreased at less than 10% of the normal ATP needed ATP. And of course, the heart muscle uses a lot of energy to pump. So in that case, the heart will die because it will lack nutrients and oxygen. So mechanism of cell death is necrosis, which is coagulative. So this is how it will appear. There is a staining called TTC. I think if you have this presentation, if you remove the full screen, you see the meaning. Sorry. So it is something, if you do autopsy, you will have to stain with it. So an area which is whitish, it is an area which is having infection. A reddish area is normal, while a whitish area, it means it is a sclerotic area, meaning there has been infection before, so you didn't know. So the myocardial tissue was replaced by fibrosis. So the whitish area here is orange.
Teacher, I can see the screen. You're not seeing the slides.
Sorry. So you can see it now?
Yes. Yes.
Okay, so I was saying this is when you want to diagnose this, for example, during autopsy, you have this TTC is tetrazolium, something like that stain. So you just apply it to the heart when you have done a cut section, and where it is red, it is the normal tissue, it will continue to be red. Where it becomes yellowish, it is an area of infection. And where it is whitish, it is an area of old infection and fibrosis. So it is a triphenyl tetrazolium chloride, that staining I was mentioning. So it detects and stains mahogany brown with reacted dehydrogenase. So when the tissue has reacted the hydrogenase, it will be continued to be brown, so reddish here. An stained area here will be the infection, while the white area, which is here, will be a scar or fibrosis, as I said. So the most common and non-specific change in ischemia, it is subcondylar myocyte vascularization. So this you can see it on history. Of course, it will not be a concern of you as a general medical doctor. So on microscopy, what you will see this is in the first 12 hours after myocardial infection, usually there are no changes. If the death of the cells happened 3 days before, you will see coagulative necrosis with neutrophils, and so on. So I think you can understand that this is very helpful to know when the person has died, because they will bring a person, a dead body. Of course, he's or she's dead. That is not the issue at that time. The issue is to know how this person died and when, because all days are very important. So then you will examine, you find the myocardial infarction. So don't be satisfied that you have found the cause, because that may not be enough for the court, the court of justice. So the police now will ask you, but when do you think this myocardial infarction happened? Because this is important.
hari n'aho bajya kubikoresha no mu mayiko niba yikora kuko ibyuma byose batabifite
akenshi ntabwo ari zose zinayikora. bagafite examen zawe bakazoreza.
So then, if you are in the district hospital, you will take a biopsy, we take a part of the heart, you send it to and especially the necrotic part or the infected part. You will send it to a laboratory of histology, then they will see if what they found. If they say there is only a fine scar or a dense scar, it means infection happens many years before. I think this can happen. This can be helpful in some cases. For example, they have found that dead body somewhere. You say it is a myocardial infarction. They can ask you when this happened, and then all this can help the investigation, the prosecutor, to know exactly when this happened. Because sometimes there are people, haba hari abantu bafashwe bafunzwe, udatanze amakuru akwiriye bashobora gufungirwa ubusa, cyangwa udatanze akwiriye hashobora gufungurwa abantu ubundi bagomba gufunga. So you must be as complete as possible. This is very important. Timing in forensic. You will learn it maybe when you learn forensic medicine. So this is what you see one day, or in fact you can see some wavy fibers and they will have neutrophils. Here neutrophils are many because it has been there for a long time, so it is like a pass and so on. So in a few weeks you have granulation tissue. Here we have, this is a special stain to detect reticular fibers, and here we have many more fibers, the blue fibers. So the reddish areas here, it is the remnant myocardial cells. Otherwise, the blue ones, these are just fibers which have replaced the dead myocardial cells. So some, as you have seen in general pathology, in cell injury, there is a phenomenon called the reperfusion of a dead tissue. And this is you have seen that it is very dangerous. When there is a reperfusion of a dead tissue, it causes more damage on the surrounding tissues. So the reperfusion can be done intrinsically, meaning that just the irrigation of the area can be done by itself, meaning that if there was a thrombus, it can resolve itself and the blood comes back to the area. Or you can give drugs. But when you have given the drugs, after 1 hour of onset of myocardial infarction, you will not rescue that tissue. If you give it within 1 hour, but after 30 minutes, as we have seen, of angina, the tissue will have died, but it can still receive the blood. But it will cause you have seen that the pathomechanism here, the problem is the free oxygen species or the free radicals. They will cause more damage when you reperfuse the tissue which had undergone infection. So when you want to intervene within the reasonable time to rescue the tissue, you must use the drug to cause clot lysis, like aspirin, as I had said. But there are more potent or more I can say efficacious drugs which are used. So post-perfusion changes, there are contraction bands with hypercontracting myocytes, stand myocardium. I think these are the things we see on histology and the electron microscopy. And there will be apoptosis by free radicals, as I have said. While in the usual myocardial infarction, there are no free radicals and there is no apoptosis. In the perfusion of the myocardial infarction, you will find apoptosis. So in the myocardial infarction, you have seen there is necrosis. When there is a reperfusion, other cells which will die after reperfusion, they will die by apoptosis, but not by necrosis. So that is explained here. We have here a heart. There is the occlusion of a coronary artery here, and then a part which was supplied by it undergoes ischemia here, So here the area is enlarged. So here there is a necrotic area. And then here we have a region. Yes, this is a region of perfusion defects area at risk. So to undergo, so is an ischemic area which can undergo necrosis or myocardial infarction. Then, if there is a perfusion before 20 minutes, you will save the tissue. So there's a salvage. If the reperfusion happens after that time, there will be a partial salvage. So some areas will be rescued, others will not. But if there is no reperfusion, the tissue will be completely infected. So you see that a reperfusion within a few hours, it can help because it can solve some parts of the myocardium, but it will not solve the whole tissue. So this is a patient who will have maybe to remain somewhere not working, not doing anything, because if he exercises, he will experience again ischemia and necrosis on that area. So silent myocardial infarction happens usually in the case of diabetes mellitus, hereditary people, or cardiac transplantation recipient. So it means they can have a myocardial infarction without pain, so no signs or symptoms. So, but how can you diagnose it? These are patients who will have a rapid and weak pulse and sweating profusely. And they can have a dyspnea. Chest pain can happen after, but in the beginning for the silent myocardial infarction, they don't have it. But these are general signs and symptoms of myocardial infarctions, not the silent one. Laboratory diagnostics, best markers are troponins, and then these are both sensitive and cardiac sensitive. Troponins T and 1. So these are enzymes that are tested, of course, for laboratories having a strong biochemistry laboratories or serology, those who can test the hormones and so on. So another one is CK creatine kinase, MB. You know, MM, it means muscles, MB, it means for heart, and BB for brain. So that's how they classify them. So MB is for the heart, BB for the brain, and the MM for just a skeletal muscle. So CRP, C-reactive protein of more than 3, if a patient is having that and has pain, so most likely this patient will have an infection. So there is a very high risk that this patient will not have a reversible condition. So the angina will progress to the infection. So the complications of myocardial infarction happens in 75% of them. And those who have who are more prone to develop these complications are this group, having poor prognosis: hereditary, females, those with diabetes mellitus, or someone who had before a myocardial infarction, or the case of myocardial infarction, so is prone to develop again another myocardial infarction with complications. And then those who have a poor prognosis again are those who have anterior wall infection. So meaning that anterior wall infection is worse than the posterior, and the posterior is worse than the inferior. So they say if an infection has to appear, at least if it happens at the inferior wall, at least that patient can survive. If it is on the posterior wall, it is worse. If it is in the anterior wall, it is worst. So understand, this is English. So the consequences then, or complications, are arrhythmia. Arrhythmia, it means, you know, the heart must pump at a rhythm. So there are patients who will come and you find that there is no well-designed rhythm. So the heart pumps maybe like it started like at a rate of 90 times per minute, and then it goes to 60, and then 30, again 90, and so on. So it is not a continuous similar rhythm, but it changes. So when it changes, you call it arrhythmia. And this is very dangerous because it causes what we call ventricular fibrillation. No kuba hagera bigasa naho ventricle aho gutera aho gupompa ahubwo igasa n'ifashwe n'amashanyarazi ikaguma muri contractions, ntigire release. So this will lead usually to sudden death in the patient before they reach the hospital. So that's why if you are at this hospital, as far as possible, you can have, there are drugs which help a patient with arrhythmia. So kugira ngo umurwayi n'umweje kuri teaching hospital or referral hospital, at least agende yahawe n'imiti igabanya risk of arrhythmia. The second complication is the pump failure, left ventricle failure, cardiogenic shock. So you know shock, I've seen it in general pathology. It can be caused by hypovolemia if someone has lost blood or has lost fluid, and other shock are caused by allergy, so anaphylactic shock and so on. So cardiogenic shock means the blood is enough, but the heart can't pump it properly. So you understand, if the left ventricle can't pump properly, then the other parts of the body, including the heart itself, will not receive enough blood. So ventricular rupture, it is another complication. If the whole thickness has undergone a necrosis, then the rupture is very possible. Aneurysm can appear, pericarditis, and then pericarditis, and it is inflammation within the pericardium, and we shall see this after, and also a recurrence of myocardial infarction. So meaning that a patient has a myocardial infarction, and they are, by chance, there are parts of the myocardium which are resolved, but after that it recurs again. So I think maybe we can have a break, and when we come, we discuss the issue of sudden cardiac death. So we are done with the usual myocardial infarction. So we can have a 10 minutes break.
We are not getting this.
I said we take a 10 minutes break.
Okay.
No, welcome again to the presentation. So we are about to start. We have to start this part about cardiac sudden death or sudden cardiac death, which is, as I had said, is diagnosed post-mortem. Okay, so there is somebody who had asked the difference between male and the females, and someone replied in the chat that this is due to the level of HDL, which might be true, or but that would be an observation. But what is behind that? Because the atherosclerosis, which is the main major player in the myocardial infarction, it is said to be more common in males, but from the after menopause, there is an equal prevalence of atherosclerosis. So that would mean that sex hormones may have something to do with the content of HDL then, which will influence that. But the main cause being the the sex hormones, because otherwise these females should continue to have enough HDL after menopause, but they don't because they develop myocardial infarction caused by atherosclerosis as men do. So the definition of the cardiac sudden death is the unexpected death in 1 hour due to cardiac causes with or without clinical symptoms. But in some other definitions, they say that the symptoms may be there for less than 24 hours. So maybe it depends on the literature. But in all, there is a sudden cardiac death, which is unexpected. Unexpected because if someone has symptoms which you think they are not intense, they are just trivial or mild or moderate, but you find the person dead. So the unexpected death is the diagnosis which is given not only in this case of sudden cardiac death, but it is given for other reasons as well. So if you find the patient maybe having just mild symptoms, you wanted to examine him or do investigations, and he or she dies just abruptly, that will be also unexpected death. And in some cases, even you don't see any signs of symptom, you just find a person collapsing and dying just on the spot. This happens. And whenever there is an unexpected death, that becomes a legal matter. So that is a dead body which must not be buried before doing autopsy or examination, or at least being before police or RIB intervene to know what is the circumstances of the death. So the main cause of sudden cardiac death is, of course, atherosclerosis. And they find that these patients, they have a long QT syndrome. This is on electrocardiogram. And they have a defect in a potassium, natrium, or sodium channel. The mechanism is most likely due to arrhythmias, because this is something which is very difficult to verify, because if it is a sudden death, there is no time to investigate what happened. So that is why here, what is written here is just the assumption. These are assumptions. Most likely due to arrhythmia, as we saw, arrhythmia cause ventricular fibrillation. So the patients, some of them, they are young athletes. I think when we are at the School of Medicine, there was a football player from Cameroon. I think they were in a cup. I don't remember if it was an African Cup. So they were just playing. He fell down and died on the pitch. So the diagnosis was sudden cardiac death. So they could not.
Sorry, teacher, we are not
Yes?
seeing your slides.
But I shared them.
No, we are not seeing.
Because even here it is telling me stop sharing. So I don't know what happened.
Some of us,
Sorry? You were
we
seeing
are
it?
seeing it. Yes.
So it
And now
was
it's
only
not.
it was only one person who did see. Yeah, because it was showing that I am sharing. Okay. So maybe you check the problem you have, but otherwise I am sharing it. So I was explaining that the person who died, he was an athlete. So, and he was dead, of course. And he was a very known, I think he was playing in the European teams. So these young athletes, or patients with pulmonary hypertension or ischemic any other ischemic heart disease, usually they die through sudden cardiac death. It means someone has just a known ischemic heart disease, which was controlled by drugs and so on, but automatically he dies or she dies. So morphology, prominent finding increased the heart mass. So meaning that the heart will be increased in size and weight. And on histology, you find vacuolation in subendocardial myocardium. So vacuoles in the cells of the myocardium. So another type of ischemic heart disease that we saw, the third one is chronic ischemic disease, or the fourth one. So because we saw angina pectoris, myocardial infarction, sudden cardiac death, then chronic ischemic heart disease. It is also called ischemic cardiomyopathy. So it means that there are pathologies or changes, abnormal changes in the myocardium, which are chronic, which are caused by ischemia. So the patient has had a lot of occurrences of ischemia, but without developing myocardial infarction. So this happens maybe most likely in a patient in a post-heart transplant recipient, so people who have received the transplantation of the heart, or who had a previous myocardial infarction to other areas, or who have this bypass, coronary artery bypass grafts. So I think someone asked how to treat. So if the patient has a clot that you cannot reperfuse, so you can do this bypass, coronary artery bypass graft. So the cause is usually compromised ventricular function. Morphology, we find the vacuoles in the myocytes, and some myocytes will have a hypertrophy. You remember the meaning, and the diagnosis is done by exclusion. So diagnosis by exclusion, I think you know it in that course of symptoms, signs and symptoms, in French called the symptomatology. So the diagnosis by exclusion, it means you have many differential diagnoses. You excluded some by laboratory or radiological investigations or electrocardiogram. Then you have others you can't exclude because or rule in because you don't have diagnostic tools to do so. So if you have excluded all the other differential diagnoses and you remain with one, that will be the final diagnosis, and you will say, I have taken this diagnosis by exclusion. So just a simple question here. Someone can chat, write in the chat concerning ischemic heart disease. The two major types. So you will choose the most appropriate statement. So the two major types are angina pectoris and the cardiac myxoma. Is that true or not? So if yes, you take that one. If not, it will not be the answer. Symptomatic ischemia, even at rest, occurs if stenosis involves 9% of coronary artery caliber. C. The risk factors of this is ischemic heart disease include hypertension, hypercholesterolemia, diabetes, smoking, and diet. D. Symptomatic ischemia induced by exercise occurs if stenosis involves 25% of the caliber, E or the above. So you choose one. So it's a multiple choice question. So I think 30 seconds will be enough. How about the others, or can you write in the chat? Okay, so if we start with A, the two major types of angina pectoris of ischemic heart disease are angina pectoris and cardiac myxoma. It is, of course, false because cardiac myxoma is not a type of ischemic heart disease. This is a tumor. So angina pectoris, if it was with myocardial infarction, we should say yes. So that is not true. B, symptomatic ischemia, even at rest, occurs if stenosis involves 90, not 9% for the coronary caliber. So it is false, this one. It is 90 instead of 9. The risk factors include hypertension, hypercholesteremia, diabetes, smoking, diet. Symptomatic ischemia induced by exercise occurs if stenosis involves 75%, not 25%. So, as someone says, the answer is C. So it is just a kind of question for you to re-evaluate yourself if you followed correctly. So otherwise, maybe we'll find a way these can be the true quizzes to be marked. So I think that's all for the myocardium. Then we go to other parts of the heart. So I've talked about the myocardium, and the diseases are mainly there's the ischemic ones. Other diseases are tumors like rhabdomyoma of the heart, but very rare. I have not seen it myself. They are rare. Others can be myocarditis, which is also rare. So we go to the other parts, the pericardium and the endocardium. So for the inflammation, maybe in general, we have endocarditis, myocarditis, and the pericardial disease. So we start with endocarditis. So endocarditis, as you understand, is inflammation of the endocardium. As I said, the main manifestation of this disease is the defects in the valves, heart valves. Can it be one valve or two or more of the four main types of the valves? So the main cause is the rheumatic fever. So rheumatic fever, maybe you have seen this in microbiology and so on, but this disease, it is a very dangerous disease. Ariko kenshi tuyifata nk'indwara yoroshye, ni indwara ituruka ku bintu byoroshye, abantu barwara angine bisanzwe cyane cyane utwana, then it progresses toward other parts of the body. So what happens is, what is said, the rheumatic fever, the problem with it is not just the infection by Streptococcus bacteria. So streptococci, they affect any person. They develop any disease such as bronchitis, such as tonsillitis. So now the issue is tonsillitis, say angina, not angina nk'izo mu mutima byensire, ni angina zino zisanzwe amygdala, zo muri amygdala. So the problem is said that when someone has an infection by streptococcus in the tonsils, if it is not treated, then the body will start to form antibodies, a lot of antibodies against that streptococcus. And unfortunately, these streptococci, they have some of their structure which are similar to the structure of the heart valves and some membrane in our joints, and even some parts in the glomeruli in the kidney. So then when the body develops these antibodies, they will destroy not only these bacteria, but only they will destroy the other components of our own body which have the similar structure. So that's why this is like an autoimmune disease. So it is a common disease in our country because I share an office at Sashika with a cardiac pediatrician. So he's I think the only one in Rwanda, cardiac pediatrician. So he's what he does of course, he's also a director of education at Sashika, but his clinical activities is to treat these children. There are many because he does the OPD on a Tuesday, and he starts at around 7:30 up to 5 p.m. He's still there. Many children coming from all over the country. So their problem is usually that their valves are completely destroyed. They have a cardiac insufficiency, so usually they need a valve replacement surgery. So because this is not yet implemented in Rwanda as a routine, sometimes it's done by experts from outside the country because they don't have infrastructure here for that. So he treats some of them. When they become stable, then he tries to find to cooperate with some clinics in Europe, especially in France and in Israel and in Egypt to be treated there. So it is not a theory; these patients are there. And when I was in the district hospital, I remember I treated 2 of them, and their treatment is very tough. I treated 2 of them, and at the end, they didn't comply with the treatment. Then I sent them to teaching hospital. So a patient with rheumatic heart disease, just when you receive that patient to the hospital, before forwarding him or her to the teaching hospital, you can start a treatment. I treat it to save the valve if it is not completely damaged. So that time we are giving, the protocol was to give strong penicillin, such as ceftriaxone, injectable in 10 days. Then the patient will be discharged home with extensilin. So extensilin injection of once per 15 days, so twice a month for 5 years. So that was the protocol. So the 2 patients I treated in the different times, the issue I had with them is that I gave the strong antibiotics, then they become very stable. Then I say, you go to health center. They had the booklet for that. So they will be injecting the child every 2 weeks with extensilin. Of course, extensilin is a very painful injection, a drug, because it's done intramuscular. So after 2, I was giving a 3 months or 2 months appointment to come back to check how they're doing. So after 2 months, they come, they are very fine. After 4 months, they don't come and they don't go to get the injections because they think they are completely cured. And they find the child after 8 months come back in a very bad condition because they didn't comply with the treatment. So that is my experience with this disease with the 2 children I have treated. So I sent them further for management. So probably if they are lucky, they have been sent for surgery, or if they are more lucky, they have been treated without recurring to surgery. So this is an infection. It can be, some are infective, others are non-infective. So meaning there are those we call non-bacterial thrombotic endocarditis. Nubwo ni abantu bafite thrombose duto kuri endocarditis, tuva kuri endocarditis itera twa thrombose duto ariko akaba atarimo bacteria, without infection, bacterial infection. Another type of non-infective endocarditis, it is caused by systemic lupus erythematosus. This is an autoimmune disease. You learn about apoptosis. In apoptosis, you know that when a cell is dead, the apoptotic bodies must be phagocytized by macrophages, and so in such conditions, there are no leakage of cell content to the environment. Therefore, there is no reaction, no inflammation. So in lupus erythematosus, the problem is that Apoptosis happens, but there is a leakage of DNA outside. So that DNA will cause a reaction. That's why this patient with SLE, one of the things you measure into their blood is the anti-DNA antibodies. So these patients, they have a lot of antibodies against their own DNA. So as such, these anti-DNA antibodies, they can destroy any other parts, including the heart valves. And especially they destroy heart valves and kidneys. So I encountered this, many cases of that during my postgraduate training in pathology. And there's one case we published because it was unusual. So another cause of endocarditis is carcinoid heart disease. So carcinoid heart disease, it means there is somewhere a cancer. That cancer, it releases some chemicals which can come and harm or injure the heart, especially the endocardium. So in that case, the patient will be said to have carcinoid heart disease because a cancer somewhere has released chemicals which came to destroy or to damage the heart. So if we start with the infective endocarditis, it is of course an infection of the endocardium, especially the heart valves, as I said, by microbial agents with the formation of thrombotic debris and organisms known as vegetation. So vegetation is even one now clinically, if we do surgery to this patient, no echography, so those who are strong in echocardiac, they will find there's a vegetation. So things looking like a shoe thread on the valves. The causes are bacteria, most commonly sometimes fungal infection, rickettsiae, and chlamydia. So if we go into details for the bacterial causes of endocarditis, they are what we call alpha hemolytic streptococci. We have Streptococcus aureus, coagulase negative staphylococci, and the HASEC group. I think this I've seen in microbiology, which means abbreviation of Haemophilus influenza, Actinobacillus, Cardiobacterium echinera, Kingera, and these are commensals of the oral cavity. Commensals means normal flora of the oral cavity, but when it arrives to the heart, it will cause problems. Others are gram-negative bacilli. So this means that if we have a patient with infective bacterial endocarditis, you must know the class of the agents which cause that endocarditis so as to treat it properly. So the predisposing factors to infective endocarditis, they are rheumatic heart disease, which I explained. They are myxomatous mitral valve, calcific valvular stenosis. So there are people who have valves which are stenotic because of the calcifications. So there are those who have artificial valves. For example, they get artificial valves, some of them, and then this can cause, can be another factor to have a next endocarditis. Then neutropenia, immunodeficiency such as HIV, therapeutic immunosuppression, ishobora gutangwa for any reason. Immunosuppression, for example, you give steroids for a long time, the immunity will go down. So if you wanted to transplant a patient, for example, to a patient to receive bone marrow or to receive a kidney, you have to cause immunosuppression. That is therapeutic immunosuppression. There is diabetes mellitus, alcohol or intravenous drug abuse, and sepsis or septic shocks. All these are factors to infective endocarditis. So pathology of infective endocarditis, there are vegetations which I explained. They are composed of fibrin, inflammatory cells, and bacteria. Yes?
I have a question.
Mm-hmm.
This artificial izi valve nyine these artificial valves bashyira mu mwana.
Yes.
Zishobora persisting for the lifespan of the child until he or she gets the organ.
Yes, of course they should, because they are there. You will not do another surgery to replace them. They must be there. They must be lifelong.
For the life of the child.
Sorry?
Can persist for the whole life of the person.
Yes, I say this. Yes, that is the intent for them. If you do a transplantation, it will be for life.
Okay, thanks.
Including the kidneys, yes. Okay, so the vegetations are located most commonly on the heart valves, especially aortic and the mitral valves. And you know that these valves are the most powerful ones because they deal with the left side of the heart. So vegetations may erode, or perforate the valve, and they may erode into underlying myocardium to produce an abscess. This is called a ring abscess. I think we had such case at Sashika. It was last year, I don't remember the month, but because as I said, I shared the office with the cardiac pediatrician, so he said he had a child who has a lot of pus in the heart. So he was there to puncture and they at least remove a part of that pus. So went together. So it takes a long, but it was successful, and the child was healed and he went back home. But there was a lot of pus when you were looking at the ultrasound. So vegetation may produce emboli that cause septic infarct. So we have talked about the types of embolism. Now here you see that if there is a vegetation in the heart, that vegetation having, of course, infection such as bacteria, that part of the vegetation may be ruptured and be transported through the bloodstream, and they go, for example, to the kidney, to the brain, to the myocardium, or other organs. So in that case, there will be infective embolism, which is more dangerous again. So this is the section of the heart, and it is showing the valve here. Sorry, any question? So here there is a vegetation. So this is a valve here, but there are vegetations here. So unusual, and they are reddish because of the inflammation here. So aka ni agati bashyizemo kugira ngo gusa berekane ko habayemo perforation. Stick in a perforation. So there has been a perforation. So if there is a perforation in the valve itself, you understand the consequences, regurgitation of the blood. That's why the patient will come with signs of cardiac failure or cardiac insufficiency. So that was a mitral valve itself. So on histology, you find a lot of, so this is the pink material here, which has no cells. This is a necrosis with fibrin, and then you have these dots, which are blackish. These are the nuclei of the neutrophils. So the clinical features of infective endocarditis, the child will have fever, chills, fatigue, weight loss, flu-like syndromes. And the mama, this is on auscultation of the heart pumping. And then the child can have petechiae around the valve. So petechiae means they are pinpoint hemorrhages. So that was the bacterial infective bacterial endocarditis. Now we go to non-bacterial thrombotic endocarditis. So this is a deposition of sterile meaning there is no infection. vegetations on the leaflets of cardiac valves. It is also called Malaria endocarditis. So the pathology, or what you see morphologically, you see vegetations of fibrin, platelet, and other blood elements, for example, thrombus. But when you do histology, you don't find neutrophils or pus or bacteria. And even grossly, you will not find the pus, because the pus is where there is there are bacteria usually, or fungi. Vegetations are sterile, non-destructive, non-inflammatory, and they are small. Vegetations will occur singly or multiply, many, along the lines of closure of the heart valves. So it means here we cannot have a perforation, but the problem, because they appear on the closure lines of the valves. When a heart valve closes, it will not close completely because of these vegetations, therefore causing signs of heart failure again. So their pathogenesis is that it is not well known, but it is thought that this disease occurs as a consequence of hypercoagulable state. So meaning someone has a lot of procoagulation factors. They seem to be with concomitant venous thrombosis and or pulmonary embolism. Something that most of these patients, they have this disease, but together with other venous thrombosis in other areas and or pulmonary embolism. It may be seen with hyperestrogenic state. For example, if a person is having a tumor releasing estrogen, extensive burns, or endocardial trauma from indwelling catheters. So for those patients having catheters in their hearts. So clinically, there will be local effect on the valve, but this is not very important as compared to what we saw on bacterial endocarditis. But it may produce emboli with resultant infarcts. Of course, the emboli here, it is, as we saw for the infective one, there will be a rupture or a part of the vegetation which can be cut and then transported through the bloodstream and cause embolism somewhere. This may eventually organize, leaving delicate strands of fibrous tissue. So meaning if it has been there for a long time, as a healing process, the vegetation will become like a normal part of that tissue, but it will be a fibrous one. It will not be covered by endothelial cells as it is for endocardial cells as it is for other parts of the valve. So the endocarditis of the systemic lupus erythematosus, this endocarditis is also called the Liebman-Sachs endocarditis. So I think in this chapter, especially the vascular pathology, you have many names of persons who discovered or described first the diseases to be discussed. So this will be small sterile vegetations. They are sterile because this is an autoimmune disease, as I said, characterized by anti-DNA antibodies. So this vegetation will occur on mitral and tricuspid valves or fibrous thickenings occurring with the antiphospholipid syndrome. So there will be circulating antiphospholipid lipids, which also are associated with venous and arterial thrombosis, and so antiphospholipid antibodies. I hope you remember the role of phospholipids in inflammation. So the antibodies against them, they are also dangerous because they damage parts such as the valves. So the pathology, what is seen in systemic lupus erythematosus affecting the endocardium, the vegetations are also small, single or multiple, sterile, granular, and pink. They are frequently located on the undersurface of the valves, atrioventricular valves, of course, AV, are atrioventricular valves. But they may be elsewhere on the valves or even on middle endocardium or of atria and ventricle. So this means that when you check them, you don't look on the valves, they can be even on the endocardium away from the valves. They consist of granular fibrinous eosinophilic material, and they have valvulitis. This is inflammation, characterized by fibrinous necrosis contiguous with the vegetation. It can result in fibrosis and valve deformity. If you remember the problems of inadequate healing or repair of the tissues. So the carcinoid heart disease, it is seen in half of the patients with carcinoid syndromes. So carcinoid syndromes, it is a syndrome seen in some of the patients, of cancer patients, especially the patients who have cancer arising from endocrine glands. So for example, if someone is having a carcinoma arising from adrenal glands, from thyroid, and so on. So they develop this syndrome, which is characterized by flushing, skin flushing, cramps, nausea, vomiting, and diarrhea. So this carcinoid heart disease, it involves endocardium and the valves of the right side of the heart. So why do you think so? Why do you think this disease only will affect the right side of the heart? So the answer is that it is thought, this is a hypothesis which would be challenged in the future, but it is written that the reason of having this on the right side of the heart is that these chemicals will be released by tumors, cancers, and they will be they will come into the bloodstream. The bloodstream will be on the will be on the venous, of course, venous side. Then the blood will come through the vena cava to the right heart. Then they arrive there. Then they cause their injury to the right heart. Then the heart will pump the blood to the lungs, and it was found, or it is thought that the lungs, they have the capabilities to neutralize these chemicals once they arrive to the lungs. So that's why when the blood comes back to the left heart, the blood does no longer contain these chemicals. So that is the explanation why this disease affects mainly the right side of the heart. So pathologically or morphologically, how it happens, the carcinoid heart disease, the patient will have intimal thickening or inside the surfaces of cardiac chambers and the valvular leaflets, mainly on the right side of the heart. There will be the thickenings consist of smooth muscle cells and sparse collagen fibers embedded in an acidic mucopolysaccharide-rich matrix that expands the endocardium. So endocardium yarabyimbye. That's why there is that thickening. Underlying structure of the heart will be intact, meaning myocardium is mainly intact, and of course a pericardium. So how does this appear pathophysiologically? The carcinoid tumors, meaning these are the carcinoid tumors, they are tumors from endocrine cells. They produce a variety of bioactive products, including serotonin, kallikrein, bradykinin, histamine, prostaglandins, and tachykinins, and others. But it is said that serotonin is the most player in causing cardiac lesions. So the explanation I was saying is here, the lesions are usually on the left, right-sided because serotonin is inactivated by pulmonary vascular endothelial monoamine oxidase. So when the blood reaches the lungs, the blood which comes to the left side of the heart will no longer contain that injurious serotonin. So there are carcinoid-like heart lesions. They can appear on the left side, but they don't call them cardiac heart disease, carcinoid heart disease. They call it carcinoid-like. So they appear as the lesions seen on the right side, but here they call they are like. So the left-sided lesion can be seen with methysergide or ergotamine treatment for migraine headache. Since these serotonin analogs are metabolized to serotonin by lungs, so you understand now the problem. So this person will take these drugs, maybe injected or per oral cavity. The drugs will reach the blood, will go to the right side. So the blood will reach to the right side of the heart and then pumped to the lungs. So when they comes to the lung, the lung will catabolize them to serotonin. And when it does that, it is no longer possible to transform that serotonin. So meaning that they are at the area whereby they have gone beyond the area where serotonin could be detoxified. So serotonin will come now to the left heart, causing problems. So I think migraine, you know it, the people have a severe headache that is called migraine. So they receive some specific treatments which are listed here. So these lesions can also be caused by fenfluramine and phentermine. These are appetite suppressors since they affect the serotonin metabolism. So abakobwa n'abadamu badashaka wenda kurya cyangwa kubyibuha bakirinda bakashaka ko batakaza apeti bafata iyo miti, then it can cause these problems to them. So that's all for endocarditis. We can go to myocarditis, which is inflammation of the myocardium. This is inflammatory process of the myocardium that results in injury to the cardiac myocytes. The causes are mainly infections, such as viruses. You have many here, Coxsackie viruses, HIV and so on, chlamydia, such as chlamydia psittaci, rickettsias, such as Rickettsia typhi, bacteria such as chlamydia diphtheriae, fungal such as Candida species, protozoa such as Toxoplasma gondii, and the helminths such as trichinosis. So all this they can cause inflammation of the myocarditis, but these are rare lesions, but you must be aware that they exist. You can encounter them as you treat patients. It is possible. So there's where infections. So other causes are autoimmune or immune mediated. So for example, after viral infection, I think you are aware about the coronavirus, that there are some patients who die because of myocarditis. So after the coronavirus, the actual coronavirus has disappeared from the body, still its effects can be seen in the heart, in the lungs, and elsewhere. So coronavirus, SARS-CoV-2, it can cause this. You know that we had coronaviruses before. There are until now 8 types of coronaviruses. The first one appears in the 1960s, and the first one was called the B814, and it disappeared. It is no longer seen in humans. And then we had other types of coronaviruses. One was called the HKU1. There's one called the OC43, and there is one called the NL6 and so on. So these ones, they don't cause epidemics. And in 2002, they became a severe virus causing severe acute respiratory syndrome, and it was called the SARS-CoV. And then now when we had this one in 2019, also it was called SARS-CoV-2, and that first one, they added one. So it is now called the SARS-CoV-1, and it is the present one, it is called SARS-CoV-2. And in 2012, there has been another epidemic of coronavirus in the Middle East, Arabia, and so on. So that one was called the Middle East respiratory syndrome, acute respiratory syndrome coronavirus. So we have until now 8 coronaviruses, but what I am talking about here is the COVID-19. So it can be seen, the immune-mediated can be seen in post-streptococcal, like in the rheumatic the fever disease I mentioned before. Systemic lupus erythematosus, drug hypersensitivity, hari nk'abantu bagira reaction cyangwa allergie kuri methyl-dopa, sulfonamides. Methyl-dopa yakunda gukoreshwa bavura ari byo mu mutwe. Sulfonamides zikoreshwa muri byinshi, harimo no kuvura some of the cancers. And also there are some who reject the transplant. Any transplant can be heart, it can valve, it can be a kidney. So when this happens, it can also affect the myocardium. So other causes. So if you are asked the causes of myocarditis, you must categorize them: infective, immune-mediated, and then others, such as sarcoidosis, that it causes granulomas, and the cause is not really very well known, and the giant cell myocarditis. So on gross pathology, the heart will appear dilated or hypertrophic. The ventricular myocardium may be flaccid and spotted by pale foci or minute hemorrhage foci. So flaccid, it means it can be hypertrophic, but it is not strong, because the muscle, when it is contracting, it must have a kind of rigidity. So here, instead of being rigid, it will be flaccid. So they may have a neurothromby as consequences or complications of them. So on microscopy, we see inflammatory cells. So maybe this is not a concern, but you must understand that on histology, there are things we look for. Inflammatory cells, lymphocytes, predominantly. There may be focal necrosis and so on, fibrosis, and sometimes you can isolate the parasites in cases of trypanosomiasis. So clinically, the patient will come with fatigue, dyspnea, palpitations, precardial chest pain. I think palpitation you understand. Avuga ngo umutima uramusimbuka. Donc cyangwa nawe ukawumva utaranakora auscultation ukumva umutima we uri kudiha, that is palpitations. So can be asymptomatic. Some patients will come with heart failure, dilated cardiomyopathy, arrhythmias, mitral regurgitation that you can hear through auscultation, and this is one of the causes of sudden cardiac death or sudden death. So meaning that when you do autopsy in the case of sudden death, you don't find a myocardial infarction, you must think about also myocarditis, which usually you will not diagnose grossly, but we need microscopy. Any question about myocarditis before we embark on the pericardial diseases and finish this chapter? Okay, so let's continue. So the diseases to see are there pericardial effusion, pericardial hemorrhage, and just inflammation without there's a two. So effusion, as you have seen in general pathology and inflammation, when the inflammation comes, there is a leakage of fluid from vascular lumen. The fluid goes first as water, and this is called the transudate. When the proteins come in, it will be called the exudate. So exudate is rich in protein, transudate is poor in proteins. So the causes may be infection, autoimmune diseases, congestive heart failure, meaning that the heart it is containing, it is failing to pump blood. It is receiving blood but failing to pump the blood forward. Renal failure, malignancy or meaning cancers, myocardial infarction, drugs or radiation. So some radiation can cause it, and some drugs. Clinically, you will see a low blood pressure, meaning this patient will come with hypotension, dyspnea, dizziness, and chest pain. If fluid compress the heart, the patient will have what we call cardiac tamponade. With severe decrease in cardiac output, when there's a fluid or anything else around the heart, which compromises the pump, the muscle to pump, then you understand that as a consequence, the cardiac output or pumping will be not optimal. And in the case I was mentioning, who had a lot of pus in the myocardium and even in the pericardial cavity, that child has this condition, cardiac tamponade. So the heart could not pump the blood, and also receiving the blood was impaired. Therefore, the child had the swellings everywhere, edema, and so on. So the pericardial, this was in general, this was pericardial effusion. Now for the pericardial hemorrhage, the bleeding, it is caused by the bleeding into the pericardial sac. This can be traumatic, or caused by surgery or any other iatrogenic cause. So you amutera urushinge, rugerayo, rutobora vessels, and so on. Cardiac rupture is one of the causes from a myocardial infarction or perforating trauma on ruptured aortic dissection. So these are the causes. So it may produce compression for the heart with resulting heart tamponade. So for pericarditis, we have many types. We have a serous. Serous, it means the fluid in the pericardium is serous, meaning it is like water. It can be fibrinous when there is water and some fibers deposit. These fibers are usually whitish, grossly on microscopy they become pink. It can be purulent, meaning it has a pus, which is called suppurative. It can be caused by hemorrhage because any membrane, peritoneal cavity, pleural membrane, and pericardial membrane, when there is a blood there, they will react. There is caseous pericarditis, maybe caused by tuberculosis, adhesive mediastinal pericarditis. So it means this patient will have the pericardium will adhere to the other components of the mediastinum. And the constrictive pericarditis, it is when the two pericardial sacs or membranes, they become adhesive to each other. So they will constrict or they will limit the movements of the heart itself. So these were types of pericarditis. Now the causes, there is infection, rheumatic fever, other autoimmune diseases, drug reaction, myocardial infarction, uremia, people who develop syndrome whereby their kidneys can't filtrate blood correctly, so urea or uric acid remains high in the bloodstream. Other causes include radiation. So serous pericarditis, that I mentioned, it is a fluid, just as a fluid. It is produced by non-infectious inflammations. So we have the causes: rheumatic fever, systemic lupus erythematosus, scleroderma, tumors, uremia, and so on. It may be produced by adjacent infection. For example, there is infection in the pleural cavity. As the reaction, the pericardium also releases a fluid, but which it has no infection in itself. Microscopically, we have inflammatory cells with neutrophils, lymphocytes, and macrophages. Slow leakage of fluid of high specific gravity and rich protein content into the pericardial sac. So if there is a lot of fluid in a pericardial sac, that will be, of course, called the pericardial effusion, and this can be caused by pericarditis. So fibrinous and serofibrinous pericarditis, so it means they combine fibrins and serous fluid. So they are mixed there. The common causes are myocardial infarction, urea, uremia, radiation, rheumatic fever, systemic lupus erythematosus, trauma, and post-infection syndrome. So here it is a picture. Maybe you will see it more clearly. You see it clearly on the screen. So this is a serofibrinous pericarditis because there is a fluid. For example, here the fluid is seen, but here there is a deposit of something more, which may be a fibrin, which is fibrin. That's why they diagnose it as a serofibrinous. And these, I think, are things you must know, so that when you do surgery or anything, if there is a fibrinous inflammation, you automatically say this is a fibrinous inflammation. You don't need a microscopy to diagnose that. It is something you can do during just surgery or autopsy. Purulent or suppurative pericarditis, there is a pus in the pericardial sac, usually from infective organisms. So, and you know, pus, what is the content of the pus? In the pus, you have dead tissue debris, you have inflammatory cells, usually neutrophils, and you have the infective agents, bacteria. So you see all of them in that coagulative necrosis, which is now transformed into a liquefactive necrosis. Because when there is a pus, it means there is something looking like an abscess. So hemorrhagic pericarditis, it has both fibrin, blood, or pus. So there is a mixture of blood with something else, either fibrin or pus. So seen in the cases of tuberculosis, malignancy, and cardiac surgery. So the caseous pericarditis, of course, you know, when we talk about the caseous necrosis, always think about first tuberculosis. So on histology, we find a granuloma, and as complications, you can have calcifications, which will cause a constriction of the heart. So the heart will be compressed by the surrounding inflamed tissue. So adhesive mediastinal pericarditis, as you had mentioned, there will be pericarditis whereby the inflamed pericardium will adhere to the other parts of the mediastinum, because you have many things in the mediastinum. So the causes may be suppurative or caseous pericarditis, cardiac surgery, mediastinal radiation, and so on. So the pericardial sac will be obliterated, and there will be adherence of the outer portion of parietal pericardium to the surrounding structures to produce great strain on cardiac function. Great strain, this will not be stain, strain. So there will be increased work of the heart on the heart, which leads to the cardiac hypertrophy and the dilatation. So dilatation or dilation, depending if you use English, British or American English. So the constrictive pericarditis may follow suppurative hemorrhagic or cautious pericarditis and so on. So I think the issue is to understand the consequences of it. So the causes are there, but the consequences are the ones causing the signs and the symptoms of cardiac failure, if we can say so. So that's the end of the presentation. If you have any question, you can ask it. So I assume that there is no question, then we see each other at 2 p.m.
turongera saa munani ariko rogera asubiremo
ibindi ese ko wayigize nyine
izo zifite slide zingahe
turahura saa munani
uje kurya abana
nuziriye mani ishema
Wepogo, vipi za usha? Aracha bipoti. Arazamutse.
présent.
Areke gusakuza mwana.
gakondo abakozi bari bazi ibintu nari narakuye iwacu